You might have sometimes observed that there are so many biologicals and monoclonal antibodies are available in the treatment of autoimmune connective tissue disorders, and some do work in some diseases, some do not work in other diseases, although the clinical manifestations of many of them are arthritis. So why is it so? I'm Dr. Neeraj to speak about why some monoclonal antibodies work in some diseases and in others it doesn't work. This is because each disease has got a biology, and the biology is driven by one type of immunological signature. So targeting that immunological abnormality would only benefit the symptomatology of that disease. That's why TNF alpha inhibitors don't work in SLE. At the same time, belimumab don't work in rheumatoid arthritis. So let's briefly delve into the biology, what drives the biology of the disease, and how the treatment targets this biology. So predominantly B-cell diseases are SLE, Sjogren, MCTD, antiphospholipid antibody syndrome, and dermatomyositis. So B-cell targeted treatment like rituximab and belimumab do work well in these diseases. While rheumatoid arthritis, polymyositis are T-cell driven diseases. So targeting TNF alpha by abatacept or even other TNF alpha inhibitors do work excellently. Rituximab is an exception which do work in both these diseases. Coming to systemic sclerosis is a fibrosis driven disease. So IL-6, anti-IL-6 and anti-TGF do work in this. And anga-associated vasculitis is a neutrophil driven disease. So rituximab do indirectly decrease anga production and do work in these diseases. So this is the exact reason why the biology of each disease should be known, and that helps us to shortlist the possible benefits monoclonal antibodies would, the specific monoclonal antibody would gain in this group of patients. Thank you.